Hello, my name is Ravi Vij. I'm from My Cancer Haven, and today in Conversations with Cancer Experts series, we're going to be talking with Dr. Adam Kittai, established CLL researcher and thought leader at the Icahn School of Medicine at Mount Sinai, New York. Welcome, Adam.
Thanks for having me, Ravi.
So we're going to talk about the future of treatment for chronic lymphocytic leukemia. And this is one of the cancers in which you folks have made chemotherapy history already. So the question is, how do we, improve upon the tremendous work that you and your colleagues have done over the years to improve outcomes? So, um, as far as the current state of the art goes, I think that the frontline treatment is mainly a choice between a BTK inhibitor and a BCL2 inhibitor. We're not going to get into those issues and how you choose. What we're going to talk about is where could this lead to in the future. So I think one of the things that is being increasingly looked upon in several trials, some of which we'll talk about, is combination therapy with BTK inhibitor and BCL2 inhibitors. So in that regard, I think the Captivate study is one that has often been talked about. Can you tell us about the study design and the key findings from this study?
Yeah, for sure. So I think that we'll have a approved BTK inhibitor, BCL2 inhibitor combination, hopefully in the next year, based off the Amplify study, which we expect to be presented at one of our national conferences very soon. But the data here is the Captivate study, which is ibrutinib plus venetoclax. And this is a phase 2 study. And it had a little bit of an interesting design where if patients had undetectable minimal residual disease after completing combination therapy for 15 cycles, they were randomized to either continuing ibrutinib or getting placebo. And if they had detectable MRD after completing 15 cycles, they were randomized to either receiving ibrutinib or ibrutinib plus venetoclax. And so I think what we're going to show today is the results of the undetectable MRD arm in those patients who were randomized to placebo. And I think that we're waiting for the final results of the Captivate study because obviously these patients do live for a very long time. And I think we won't get final results for some time now. And so what we're showing here is the primary efficacy of that particular arm of the study, the time-limited arm of the study. So what they found was that the 24-month PFS was remarkable at 95%, and was also high for those patients who had high-risk features such as deletion 17p or TP53 at 84%. We also showed that 90%, 92% of patients were able to finish study treatment. And really, when we looked at the adverse events, we didn't see any new signals. So there was nothing new that came up when combining a BTK inhibitor or BCL2 inhibitor. But basically what we expect to see when we give these two drugs individually, we saw together on this particular study. And then when they looked at the MRD results, they showed high levels of undetectable minimal residual disease, especially for those patients who did not have a deletion 17p, and that's in the blue. And as you see, too, another take-home point from this study was, although MRD was different when we looked at it in the peripheral blood or the bone marrow, they were pretty much similar, at least off by 10%. So the question becomes, do we need to check MRD in the peripheral blood in the future versus the bone marrow? Time will tell, but it's pretty concordant, at least in this study and some other studies that came after it. Now, interestingly here, patients who were deletion 17p TP53 had higher discordance between peripheral blood MRD and bone marrow MRD. And we do need to find longer term follow-up to see how these patients with high-risk disease perform. Because the general sense here in CLL is that patients who have high-risk disease should not be getting time-limited therapy. They should be getting continuous therapy. But there is another study currently ongoing, the CLL-17 study, which is a randomized study of ibrutinib to venetoclax plus obinutuzumab to ibrutinib plus venetoclax that will be more informative about whether or not we really should be avoiding time-limited therapy for patients with high-risk disease. But certainly, we were all excited about the results of the Captivate study. Unfortunately, the combination of ibrutinib plus venetoclax was not approved in the US. It is approved in Europe, and that's based off the GLOW study. And it was not approved in the ibrutinib plus, it was not approved in the US because there were some higher death signal at the beginning of treatment in that particular study. So we don't expect this combination to be approved soon for patients with CLL, or maybe ever. But we do expect, based off the results of the Amplify study, which we are making a statement based off of just pharmaceutical report as opposed to actual data, that acalabrutinib plus venetoclax plus obinutuzumab will likely be approved sometime in the next year.
And what about this other ibrutinib venetoclax combination study with CD20 monoclonal antibody, the CLL13 trial?
So this study caught me off guard because I was not paying attention to it until it got presented, and it actually had some really interesting results. And so here's one of the first studies that compared the triplet ibrutinib venetoclax plus obinutuzumab to the doublet venetoclax plus obinutuzumab to the doublet venetoclax plus rituximab. And if someone were to show me the study design, I probably would have said something like, I would expect the venetoclax arms to be fairly similar in the front line. I don't expect them to be much different. But let's cue to the results, and I'll tell you exactly what the story here was. So the interesting result of this study was that patients who received venetoclax plus rituximab did much worse than those patients who got one of the obinutuzumab arms. And the VR is in the green, whereas the VO and the IVO are in the blue and the orange. And so I think what this study has two take-home points. Number one is that obinutuzumab is the superior anti-CD20 monoclonal antibody for patients with CLL. And I should add that this wasn't the first time that this was studied. There was a study of chlorambucil plus obinutuzumab versus chlorambucil plus rituximab that also showed similar findings. But that was done, many years ago. The other take-home point here too is that it's unclear if ibrutinib is adding anything in this triplet. Now there is some longer-term follow-up that's been presented that looks like the blue and the orange lines are separating a little bit more in favor of the ibrutinib regimen, but I think we need more time to tell for that. And I think we're going to also show the MRD results of the study in a little bit as well.
So talking about MRD, obviously MRD is another hot area, not only in CLL, but in a lot of heme malignancies. And the Captivate study obviously is trying to address this in one manner. But first, what do you use MRD for today in your own practice?
So MRD can be calculated in 4 different ways. It could be done by peripheral blood flow or bone marrow flow, which is undetectable to the level of 10 to the negative 4, or it can be performed using clonoSEQ, which is the only FDA-approved sequencing test for MRD testing, and that can detect up to 10 to the negative 6, and that can also be done in the peripheral blood or in the bone marrow. So currently what I'm doing is I am using the clonoSEQ testing for patients who complete time-limited therapy with either VO in the front line or VR in the second line. And the reason why I do it is I do it as an informative method. So if patients don't reach 10 to the negative 4 after completing VO in the front line after 1 year, then I know that they're going to have a significantly shorter time to next treatment than those patients who do reach undetectable as determined by less than 10 to the negative 4. I also typically do it just in the peripheral blood. As I said, most of the studies, the concordance between blood and marrow are pretty concordant. And so I don't see the necessity until there's an actionable reason why I would act on someone who has bone marrow positivity in terms of their undetectable minimal residual disease. So right now I'm just using it as an informative measure for my patients to give them some guidance about how long I would expect them to be in this treatment-free interval after completing time-limited therapy.
Would it be both for frontline and relapsed refractory time-limited therapies?
Both for frontline and relapsed. In relapse, there is one other thing that I do pay attention to. So if I have an older patient who is relapsing after venetoclax plus rituximab, or I should say, who is not totally an undetectable minimal residual disease after completing venetoclax plus rituximab, and they tolerated the venetoclax plus rituximab really well, and I really wouldn't be so keen on starting a new medication, and maybe they had high-risk features, that's somebody who I may use the MRD testing to help me decide if I'm going to stop therapy altogether or just continue them on as venetoclax as a single agent. So although we don't use venetoclax as a single agent continuously very often in CLL, I will remind people that it was studied that way in the original trials. And so it's totally reasonable for someone who's older, who tolerated the venetoclax, who you are nervous about stopping the venetoclax because they haven't reached undetectable disease, or if they have high-risk disease, that's somebody who I might use this testing to inform my actual practice, as opposed to being informative of when I expect them to be not in their treatment-free interval anymore.
So in the Captivate study, obviously, MRD was part of the trial design. What can you tell us about it? And do we have any hints yet about what the trial is likely to show?
No, not yet. But there has been some recent data that shows that patients who have baseline high-risk disease do better with continuous therapy. So we might be able to speak to that based off of this randomization, but time will tell, and we don't have enough data just yet.
And you did mention in MRD in the CLL 13 study. So what do we know here?
Yeah, so once again, it showed that the patients who were treated with VR did much worse in terms of inducing undetectable minimal residual disease than the orange and the blue, which is the VO and the IVO arms. And once again, it showed that VO and IVO did induce similar rates of undetectable minimal residual disease. So it calls into question whether or not we need the ibrutinib. One thing to pay attention to, there was a recent article that was just published in JCO last week by Dr. Othman Al-Sawaf that looked at MRD as a surrogate endpoint for PFS and OS. And it did once again reiterate that undetectable minimal residual disease is a surrogate for PFS and overall survival, justifying its use in further clinical trials into the future.
And another topic that is hot these days is resistance to BTK inhibitors. And what do we know about mechanisms of resistance to BTK inhibitors?
So when patients are put on continuous BTK inhibitors, as opposed to time-limited BTK inhibitor, which I just showed you some data about, they are at risk for developing resistance mutations. The primary resistance mutation that has been identified is a cysteine to serine mutation at the 481 residue, otherwise known as C481S. And this C481S mutation prevents binding of our covalent BTK inhibitors, ibrutinib, acalabrutinib, and zanubrutinib. So at this point, we have some data that shows that patients who develop a C481S mutation have around just a year before they will actually progress. But I have seen some patients who develop this mutation and take much longer to progress. So it's not like a sure thing that once they develop this mutation that we should change therapy. That's a question that is currently being asked by a couple of clinical trials. But for now, if someone develops the mutation, if you are actually testing this mutation longitudinally, I don't switch therapies right away. I wait till actual progression. So similarly to the MRD, this is not really an actionable test. I think that if you have a patient who progresses on a covalent BTKI, you should switch to pirtobrutinib, and we'll discuss that in the next couple of slides, or the BCL2 inhibitor venetoclax. Now, something of note to pay attention to is that C481S is not the only mutation on the block. Another mutation to pay attention to is the L528W mutation, which is actually a kinase dead mutation. And the reason why this is important is that not only does this confer resistance to our covalent BTK inhibitors, but it also confers resistance to pirtobrutinib, the non-covalent. And it looks like this mutation is popping up in some patients who are taking zanubrutinib as well as ibrutinib. So we're going to be looking at this longitudinally to figure out who is at risk for developing this specific mutation. But it looks like we will need to develop new therapies for patients who do develop this mutation, because our current BTK inhibitors don't do the trick. And some therapies that are currently in the pipeline are things called BTK degraders, which bind differently than the classic BTK inhibitors and utilize the classic protein degradation pathway to degrade BTK. So it's not reliant on the same binding capacity and does overcome patients who have the various BTK mutations that we currently are aware of.
So do you routinely test for BTK mutations?
No, I don't routinely test for them. But if I have a patient who, let's say someone had been on ibrutinib and they were on ibrutinib for quite some time, but I wasn't following them at the time because they weren't my patient, and then they come to see me and they were off the ibrutinib for some time. Maybe they went on venetoclax, maybe they stopped the BTK inhibitor because of toxicity, who knows? And now they're not doing well on venetoclax, maybe they're progressing on venetoclax. That's someone who I would order sequencing on to take a look to see if there's presence of a mutation from the past BTK treatment. because if they do have a mutation, I would favor switching directly to pirtobrutinib. But if they don't have the mutation and just stopped the prior covalent BTKI due to toxicity, then they could maybe go on a different covalent BTKI. So that's when it would kind of change my decision. And that's when I typically would test. Other reasons to test the mutations are really, really research-based.
So you mentioned the uh, covalent, the reversible non-covalent BTK inhibitors. And so what is the difference in their mechanism of action? Why does one work when the other stops working?
That's a great question. So as we see here on the left, the C481S mutation interacts with the binding of the covalent BTK inhibitors, preventing them from binding. So the non-covalent BTK inhibitors bind at a separate domain and bind differently than the classic covalent BTK inhibitors. Thus, they can work in patients who have the C481S mutation.
And so you mentioned pirtobrutinib. So obviously it's now on the market. And what is the data for this drug?
So this is the results of the Bruin study, which was quite a large study that had multiple different arms, but this is just those patients who had CLL. This was 282 patients, which is quite a large study, especially in the relapse setting. And these patients had to have received prior covalent BTKI, and they may have received prior BCL2 inhibitor. About half of them received prior BCL2 inhibitor. And as you see here, no matter if they had received prior covalent BTKI or prior BCL2 inhibitor, the drug really worked and induced a response. Now, there were a few CRs, but that's classic in CLL, and I don't mind that as much. So these patients were able to get into a partial response, and these responses were durable with a median PFS of around 2 years.
And I believe there are other drugs in this class now in clinical trials, one of which is nemtabrutinib. Is this something that has advantages that you know of over pirtobrutinib potentially?
Unclear. At this point, nemtabrutinib has not been compared to pirtobrutinib. I'm not sure if they ever will be compared to each other. And so I would just view this as another non-covalent BTK inhibitor that's currently being studied, just like acalabrutinib and zanubrutinib were being studied at the same time. So we'll see more data on nemtabrutinib as time goes on. And obviously, we'll do various different comparators of the two trials to try to get an idea of which one might work better. But I think at this point, it's really unclear and it's hard to say. As you see here, the numbers of patients who were enrolled onto the study were much fewer than the Bruin study. So we need more data to decide about which drug works better, and it's going to be a little bit of a hard decision to make, I would say.
So with all these modalities and the new drugs, how do you today think of sequencing, and where do you think sequencing is going in the future?
So this is a really good slide. I really like it because it gives you kind of all the options that patients can have. And the problem with sequencing in CLL is that given our drugs just work really well, it's very difficult to determine if there's an overall survival benefit at this point because you have to follow these patients for a really long time. And unfortunately, we haven't had any randomized phase 3 studies that are comparing covalent BTKI to BCL2I until the CLL17 study, which hasn't even read out and likely won't read out an overall survival difference in a very long time. So at this point, I think, in my opinion, it's very patient-centered. And so for the most part, BCL2 inhibitors and BTK inhibitors have both been studied in frail and fit patients, have both proven overall survival benefits in various different arenas versus chemoimmunotherapy. So I kind of view them very similarly in terms of their efficacy. So ultimately, and I know there's probably another video on this for treatment-naive CLL and sequencing, but really I focus on patient preference and I use various comorbidities to decide which treatment to use for patients. Now, I think that what might disrupt this model is once combination PTKI plus venetoclax gets approved. And how it will disrupt this model, in my opinion, is it likely will disrupt the decision of whether or not to put somebody on BCL2 inhibitor plus an infusion versus BCL2 inhibitor plus an oral medication. So 2 orals versus an oral and infusion. And so I think note 3 and 4 here is where maybe it would come into play. But time will tell about whether or not the combination of BTKI plus venetoclax is superior or the same or has equal safety as BCL2 inhibitor to anti-CD20 monoclonal.
So today, for a person who is taking a first or second generation BTKI inhibitor, how do you think through whether to go to a BCL2 inhibitor or to go pirtobrutinib? I understand pirtobrutinib right now is for patients who have had two prior lines, so it's not a probably even an option to consider in second line. But if it moves into an early line, how will you decide which way to go?
So it depends on the patient. And the reason why it depends on the patient is that at this point in time, there have been enough patients where I've had that conversation at the start of therapy where we had both a covalent BTK inhibitor and BCL2 inhibitors available. And we picked covalent BTK inhibitor to start for a reason, right? Whether it was somebody had renal dysfunction or they had big lymph nodes or they just wanted, the easier startup medication. But we picked covalent BTK inhibitor for a reason. So if at this point someone is progressing on a covalent BTK inhibitor, they probably have that same reason in place, right? Especially if it's renal dysfunction. So for renal dysfunction, I would probably just switch to a non-covalent BTK inhibitor directly and save the BCL2 inhibitor later on. But once again, I think that you just got to look at the patient in front of you, decide if moving forward with venetoclax is the wise option for someone who's progressing on a covalent BTK inhibitor versus using pirtobrutinib. And I think that there is some justification here for using pirtobrutinib directly after a covalent BTK inhibitor. And that's also coming out of the Bruin study, where patients who were BCL2 inhibitor naive had a longer PFS than those patients who were BCL2 inhibitor exposed who received pirtobrutinib. And the difference was close to 8 months. And so I think that might justify going directly from a covalent BTK inhibitor to pirtobrutinib, but I will put a caveat star to that in that some patients at that point may want a therapy where they can stop it, right? So that's something that I pay attention to, and they can't stop pirtobrutinib, but they can stop VR or VO in the second line. And in addition, even though we know that patients did better with pirtobrutinib if they did not receive venetoclax first, we do not know how those patients did who got venetoclax after pirtobrutinib. So until we know that sequencing, we can't really say for certain that pirtobrutinib is the correct drug to use after covalent BTK inhibitor directly.
So when both fail, BCL2 and BTK inhibitors, what is the outcome today for these patients?
Yeah, so this still remains an area of unmet need. So this data was pre-pirtobrutinib, but it kind of gives you an idea that these patients continue to have poor survival. So on the top right is overall survival from the start of the immediate next line of therapy after getting covalent BTK inhibitors and BCL2 inhibitors, and the overall survival was 2 years. I would guess that most of these patients got pirtobrutinib or got some clinical trial, but it's kind of hard to know looking at this data. And then if you look at the top left, time to real world progression or death after the immediate next line of therapy, this is the PFS is only 8 months. So now we have two good options. We have pirtobrutinib, which we just discussed, and we'll have CAR T cell therapy, which we'll discuss at the next slide. But I will say that patients who have double refractory disease continues to be an area of need. Even with pirtobrutinib, the PFS is only around 20 months.
So obviously we've talked about pirtobrutinib, but what are your views on the utility of CAR T cells in this population today?
So this was a really welcome addition to our armamentarium for patients with CLL. So for those that don't know, CAR T was actually originally studied in patients with CLL. The first three patients that CAR T had CLL, but there have been issues with the development of CAR T over the last 10 years, mainly because CLL induces a T cell exhaustion. And how to overcome that T cell exhaustion is still a question to this day, and is actually probably reflected in this trial to some extent. And so in this trial, patients had received a BTK inhibitor. Most had received also BCL2 inhibitor. And as you see here, only 10 out of the 50 patients had gotten into a complete response for those patients who had received both a complete a covalent BTK inhibitor and venetoclax. And those patients who got into a CR did quite well, where none of them progressed at the last update of this data. Unfortunately, those patients who did not attain CR, which is the majority of the patients, right? Those patients had much less improvements. And so the median PFS here is only about a year with a median overall survival of about 30 months. And so overall, I think that patients who are able to get into complete response do quite well, but this is really a subset of patients. And we need to figure out who is more likely to get a complete response. And there was some recently updated data from Dr. Weirda from MD Anderson that showed that patients who had bulky disease going into CAR T did worse, which is a classic thing that we see with CAR T across hematologic malignancies. And we also need to figure out if there's any other drugs that we can pair with CAR T to make it more effective. One of the most ideal combination partners is likely going to be BTK inhibitors because there is some good data showing that BTK inhibitors may reverse T cell exhaustion in patients with CLL. So I would say that I kind of reserve the liso-cel for patients who are younger, who could tolerate CAR T cell therapy. But I will also say that anyone who I'm putting on pirtobrutinib, who's received both a covalent BTK inhibitor and a venetoclax, who I expect only to have a median PFS of 16 months on pirtobrutinib, that patient too, I'm also having active discussions about whether or not we should move with CAR T when they get into a nice response with pirtobrutinib.
Anybody you would favor giving liso-cel over pirtobrutinib in the sequence?
I would say that most often I will be giving pirtobrutinib before liso-cel. That being said, I think that for some patients, I'll be using the pirtobrutinib as a nice bridge to liso-cel. And so I think I'm going to be using them in combination because every single person who I put on pirtobrutinib, I'm going to be thinking about what I have to do next, knowing that the pirtobrutinib will only last maybe a little bit less than 2 years.
So what else is coming down the pike for patients with CLL that you have your eyes on?
So we already talked about BTK degraders. There's a few in addition to the NX-2127. There's also a Beijing product and an Accutar product that are currently in development. And so I'm excited to see where these BTK degraders go and whether or not they will work better as they are brought into earlier lines of therapy. And they do have some good preclinical activity and some published clinical activity that looks like that they work in patients, even those patients who have progressed on pirtobrutinib. Now, bispecific antibodies, epcoritamab, mosunetuzumab, glofitamab, they're all being studied in CLL. I think that bispecific antibodies will have the same issues with them as CAR T cell does, where T cell exhaustion is going to be a big issue. And so once again, figuring out what to pair with the bispecific antibodies in CLL, I think is going to be an important question. But certainly, I think, patients who have double refractory disease continue to be an area of unmet need. But I will say that we've made some massive progress in CLL, and these patients are living longer and longer, and I'm excited to see what's to come for the future.
So to sum it up, in 5 years from now, for our audience, what do you think the paradigm of treatment with CLL will be? I'm sure there will be not one fit strategy still, but where do you think that the trends will lead us?
I think that if I were to have a crystal ball, that we will be using more combination BTK inhibitor, BCL2 inhibitor. I think that we will still be using continuous BTK inhibitors for patients who are older or have comorbidities, because we do know those drugs are remarkably safe and work remarkably well. And the question happens, after patients go through their front line of therapy, whether that will be new drugs like degraders or more combination therapy, time be told. But I do think that we are developing new drugs that work better and are safer than what we already have. And the future remains bright for CLL, where I am hopeful that we will have a cure in the next decade.
Well, I really appreciate you taking the time to educate the audience about where the field is moving, and I hope I can have you back on a future program to tell us as the landscape evolves.
Thanks for having me. This was a pleasure.
Thank you.